Welcome to the Wednesday webinars. Looks like quite a few people are still logging in, so we'll just give it another 30 seconds or so, and then we'll start. Good afternoon, and welcome to this week's National Bleeding Disorders Foundation Wednesday webinar. My name is Fiona Robinson, and I'm the series host. The title of today's webinar is Discover a Treatment Option from HEMA Biologics for the Hemophilia Community. We'd like to extend a special thank you today to HEMA Biologics, whose support made this webinar possible. This webinar is being recorded. The recording will be available shortly after it ends on the NBDF website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your question by using the Zoom Q&A feature at the bottom of your screen. And you can put your question in there at any time during the webinar. Following our speaker's presentation, we will put your questions to them. Unfortunately, for technical reasons, we have to end the restream to LinkedIn, Facebook, and YouTube just before the Q&A. So if you want to be part of the Q&A, please make sure that you're joining us via the Zoom platform today. And as we are going through our webinar today, we'll just have one of my colleagues drop a link into the comments of those platforms, so you can come over and join us on the Zoom platform if you want to. Today, we are joined by Dr. Guy Young, Director of the Hemostasis and Thrombosis Center at the Children's Hospital in Los Angeles. And I'd like to thank Dr. Young for joining us today, and I'll pass things over to him now to get us started.
All right, thank you very much, and thanks for the invitation to speak to you all. And as you can see from the title, we'll be talking about a drug called 7-Fact, excuse me, also known as coagulation factor 7A, recombinant JNCW. You may have also heard it called Eptacog beta. Just a little bit about me, including a kind of old picture. I really need to update my profile pictures, but in any case, so you heard where I'm from. Those are basically my titles, and we can move on to the next bit. So here's the overview of our talk today. Just a little bit brief outline about inhibitors, because as you'll see shortly, 7-Fact is a medication that is only to be used in patients with hemophilia A or B with inhibitors. So we will be discussing a little bit of background on inhibitors. And then we'll discuss what 7-Fact is, how it was studied, results of what we call the pivotal trial, the trial that got it licensed, which is called PERCEPT-1, and then why you might consider 7-Fact for your patients. And then finally, we'll close with just some of the support programs and where you can learn more about 7-Fact. So, what is an inhibitor for those who are not familiar? An inhibitor is basically an anti-drug antibody. So it's an antibody against the factor replacement therapies, which then renders those ineffective. So a patient with hemophilia A may develop an antibody to factor VIII, meaning that factor VIII treatments will not work so long as the inhibitor is present, and same for hemophilia B. And we measure that in a laboratory test, which is called the inhibitor titer. And the inhibitor titer is, the units of that are Bethesda units, or BU. Essentially, if their Bethesda units are less than 5, we call that a low titer inhibitor. And it is possible that your body could still respond to factor VIII or factor IX, albeit with higher doses. But that's not always the case because some patients who have a low titer will rapidly escalate their titer if they're exposed to factor VIII or factor IX. So it's not automatic that you can just use factor VIII or factor IX for such patients. If the titer is greater than 5, that is a very high level of an antibody or an inhibitor, and factor VIII or factor IX cannot be used in such patients at any time because it simply will not work. And in the figure on your right, you see kind of what the antibody might look like. The Y-shaped gray part in the bloodstream is the antibody gobbling up factor VIII or blocking factor VIII, and in the lower figure, factor IX. Excuse me. And inhibitors are considered really the most serious complication in hemophilia. Still today is a really serious complication. So who might develop an inhibitor? Essentially, any patient with hemophilia A or B can develop an inhibitor, and we almost always see these developing before 50 exposures to clotting factor. So typically, this would happen relatively early in life. Once a patient has reached 50 exposures, you can almost think of it as 50 doses, although we refer to an exposure as any day in which a factor product was given. So if you get 2 or 3 doses for some reason one day, that would still just count as one exposure. So if you're on factor prophylaxis, regardless of which product you may be on, the likelihood of developing an inhibitor, you can actually count your exposure days. So if you're on a weekly factor, regardless if it's Hem A or B, then it would take just about a year, right? Because a year is 52 weeks to get to 50 exposures. If you're on twice a week, then it would be about 6 months. The other thing we know about inhibitors is that they're much more common in hemophilia A, somewhere around 20% in hemophilia A, and depending on what you read, could even be higher, and somewhere around 3%, basically like 3 to 5% for hemophilia B. So, and hemophilia A, of course, is more common in general than hemophilia B. And so therefore, inhibitors are much more commonly seen in hemophilia A, partly because hemophilia A is more common, and then also because inhibitors to factor VIII are much more common, as you can see here. But there are other classes of individuals who are more likely to develop an inhibitor. So first, patients with severe hemophilia. So if you have severe hemophilia, in fact, the vast majority of inhibitors occur in patients with severe hemophilia. It does happen in moderate and mild hemophilia, but it's much less common, closer to maybe 1 or 2%. Also, if patients are Black or Hispanic, they are more likely to develop an inhibitor. In Black patients, it's about 2 times more likely than Caucasian patients, and in Hispanic patients, it's about 1.5 times more likely. The other is people have a family member with an inhibitor. So if you have a brother with an inhibitor, you're very likely to also develop an inhibitor. If it's an uncle or a grandfather, it's also more likely, although not quite as likely as if it's a sibling. And then certain genetic mutations make inhibitors more likely as well. And we still have this unmet need in on-demand bleed treatment. So with advances in prophylactic treatment, we have reduced annualized bleed rates. So overall, especially for patients without inhibitors, but these days also for patients with inhibitors, with the new medications that have been around now, emicizumab for many years, and some of the newer medications that are subcutaneous for hemophilia B that can be used. We have made significant advancements in prophylactic treatment, mostly with factor products and more recently with non-factor products. So overall bleed rates are lower. However, all of these treatments, including all the new treatments, breakthrough bleeds still occur. So patients are still likely to have to treat bleeds regardless of whatever prophylactic product they are on. And this may require a day or even several days to resolve, and may require multiple infusions. And it's even more common in patients with inhibitors who may be on a prophylactic treatment with a non-factor therapy. Again, with all of those therapies, patients do still have breakthrough bleeding events and still require then factor replacement. And for inhibitor patients, that would mean a bypassing agent. And so that often will require multiple IV infusions over a period of day or days to resolve. And rebleeding also tends to be common. So another important message is that early treatment of bleeding episodes is especially important in hemophilia, because the more we wait, the more blood builds up in the joint, and that's going to result in more joint damage and also result in that bleed taking longer to resolve. So the two key points I'm trying to make here as we go in to discuss 7-FACT is that we are wanting a treatment that will resolve bleeds quickly as possible, and also a treatment that can resolve bleeds with as few doses as possible, because no one likes to do IV infusions. And so continuing with this theme, if we look on these scales of burden, comparing patients with inhibitors, so on the right side of the scale, with inhibitors on the left side of the scale where it says WI, versus on the right side of the scale without inhibitors, there's still a higher burden of treatment for patients with inhibitors. In other words, more doses are needed to treat bleeds. So for example, without an inhibitor, what we found in both Hem A and B with the products that we have available is that most bleeds, in fact, greater than 80% of the bleeds, will resolve with one infusion across all the different products. But for patients with inhibitors, that is much less likely. In fact, the data that has been shown is that it often requires, as I said before, multiple doses, possibly over even multiple days. And so that's where, for patients with inhibitors, treating a bleed on demand, even if they are on a prophylactic medication, results in a significant increased number of infusions over patients without inhibitors. And that's what we mean by this lack of health equity between the two communities, the inhibitor community and the non-inhibitor community. So with that, we're going to now talk about 7-FACT. So first, I need to read this slide to you. So 7-FACT, or coagulation factor 7A recombinant JNCW, and I will just call it 7-FACT going forward, is indicated for the treatment and control of bleeding episodes occurring in adults and adolescents 12 years of age and older with hemophilia A or B with inhibitors. So just briefly unpacking that, this is only for bleed treatment. It is not for prophylaxis. So 7-FACT is only to treat bleeds. Second, it is only approved in patients older than 12, but it is approved for both hemophilia A and B patients so long as they have an inhibitor and cannot use factor replacement therapy. 7-FACT is not indicated for the treatment of patients with congenital factor 7 deficiency. And that's written there, you might be wondering, and that's because there's another factor 7A on the market. We'll mention it a bit later, but you probably have heard of it, called Novo-7. That one is approved for factor 7 deficiency. So it's just to clarify that 7-FACT is not approved and not indicated for factor 7 deficiency, even though the other factor 7A is. And then we have something called a boxed warning, which is a sort of a special warning the FDA puts out. So it's in this box, as you can see. And if you see the prescribing information, you'll see it in this box. And it says, warning, thrombosis. Serious arterial and venous thrombotic events may occur following administration of 7-FACT. Discuss the risks and explain the signs and symptoms of thrombotic and thromboembolic events to patients who will receive 7-FACT. And monitor patients for signs or symptoms of activation of the coagulation system and for thrombosis. So your doctor will discuss with you, and we'll mention a little bit later what those signs and symptoms may look like. So let's jump into how 7-FACT works. So it works quickly at the site of bleeding. And so that's the whole point, is so you can kind of move on with your life. And we'll show you the data on what I mean by quickly. But basically, 7-FACT works in three ways. On the left side, we have a way that it works with the coagulation proteins, and it basically helps to generate a thrombin by combining with factor 10A and then also factor 5A. So that leads to this, what we call thrombin burst, that you see in the middle of the screen. And the thrombin is the key enzyme of the coagulation cascade, because it activates platelets and it also converts fibrinogen to fibrin, which is actually the protein that structurally makes the clot. It's called fibrin because it's comprised of fibers, and you can actually see those fibers under the microscope. So this thrombin burst is really important. But in addition, 7-FACT also works in another pathway, which we call the endothelial protein C receptor pathway, or EPCR. It's an additional mechanism by which 7-FACT works. And this is a mechanism that essentially is blocking a substance called protein C from breaking the clot down, right? So if you have hemophilia and you're not really generating a lot of thrombin, and you're not making the best clot, shall we say, the last thing we need is for the body's other part of the system, which is to basically inhibit thrombin and interfere with clot formation, to be active. And by 7-FACT combining with EPCR, it is able to slow the process down that actually inhibits thrombin. So those are really the ways, the three ways that, or the mechanism of action of 7-FACT. So how was it studied? Well, it was evaluated to see whether it was safe and effective in the treatment of patients with mild or moderate bleeding episodes. Successful treatment meant bleeds had to be controlled at 12 hours, no further increase in pain after the bleed was controlled, and no requirement for any alternative treatment, meaning anything other than 7-FACT through 24 hours. And in the figure, we're pointing out that we're going to look at the primary endpoint, which is the main endpoint of the study, which is at 12 hours, but then we'll also look at the effectiveness of 7-FACT through 24 hours. There were 27 participants in the study, age range 12 to 54. And while it's a small number of participants in general, although for an inhibitor study it's not that small, the key point here is these participants treated 465 bleeding episodes, about on average 18 bleeding episodes per individual. So many, many bleeds were treated in this study. So a few important terms. So one of the key criteria was that this was a home treatment study. So patients received this study medication, 7-FACT, at home. And they would treat just like they might treat if they were not on a study at home on their own. And patients would then need to record the response to treatment. And they were given essentially a card that has this information, which says that the response to treatment is one of four. Either it's excellent, meaning full relief of pain and cessation of objective signs of bleeding. In other words, basically the bleeding stopped and no additional infusions of 7-FACT were needed after that point, that the bleed was rated as excellent. Then there was good, which means that the symptoms of the bleeding had largely been reduced. So the bleed was substantially improved, although the symptoms did not fully disappear. But the symptoms improved enough to not require more 7-FACT. And then there was moderate, which is there was some effect, but the bleeding continued and more 7-FACT was needed, or none, where there was no noticeable effect of the treatment. In order for the treatment to be deemed successful in the study, when we do the statistical analysis of the study, the patient at home had to rate it as either excellent or good. So that was considered a satisfactory therapeutic response. Moderate or none was unsatisfactory. The other term that you're going to hear me use is IDR, which stands for initial dose regimen, which basically refers to the first dose of 7-FACT given for each bleed that was treated in the study. And 7-FACT is unique because it has two different initial doses, or two different IDRs, the initial dose regimen. One is called the 75 IDR, and the other is the 225 IDR. 75 basically just means 75 micrograms per kilogram, which is the dose. So yes, 7-FACT is a weight-based drug. When your doctor prescribes it, they will check your weight, and then they will apply one of these two doses to your prescription for your initial dose. Ongoing doses, as I'll show you later, are all 75 micrograms per kilogram. For severe bleeding episodes, there was only one dosing regimen that was used, and we'll discuss that as we go along. So let's take a look at the clinical trial. So first, who are these 27 subjects? So you can see the vast majority were hemophilia A patients because of what I stated earlier about hemophilia A being more common and inhibitors to hemophilia A being more common than inhibitors in hemophilia B. And also I mentioned that severe hemophilia is much more likely to result in inhibitors. So you can see most of the patients had severe hemophilia. Their baseline factor levels on average was less than 1%. And the inhibitor status based on the Bethesda titers included below. But some of that language there is complicated. I think suffice it to say what that is telling us is that these 27 patients could not respond to factor 8 or factor 9. They had to use a bypassing agent. So if we look at the two treatment protocols, or the two essentially treatment approaches, so if we look at in the purple is the 75 IDR, so 75 micrograms per kilogram. That would be the first dose given. So we call that hour 0, the moment you give the first dose. After that, patients could, they did not have to, but they could give additional doses of 75 micrograms per kilogram every 3 hours. So they can give one at hour 3, 6, 9, and so on. At home, the patient would stop treatment once they felt their bleed was resolved, which could be at any point on that timeline. For the higher dose in orange, the 225 microgram per kilogram IDR, they would get a dose at hour 0, which is, of course, the first dose to treat the bleed. And then after that, they could not give another dose until hour 9. So they had to wait 9 hours. And then they could give additional doses at hour 9 and subsequently every 3 hours. So you can see that after hour 9, the two dosing regimens look the same. Before hour 9, they're different. And if a patient on the 75, the lower IDR, gave an additional dose at hour 3 and 6, then by hour 9, both regimens would have used the same total dose of 225 micrograms per kilogram, because 225 is 3 times 75. So that's how the patients were told to treat their bleeds. And again, any point along this timeline, including even after just the first dose at hour 0, a patient could determine that their bleed stopped. In other words, hemostasis was achieved, and then they could stop. At that point, they would not give any further 7-FAC, and that's for both arms. So what types of bleeds were treated? So, of course, mostly joint bleeds, because that's where hemophilia patients tend to bleed. Knees, elbows, and ankles being the most common, but you can see bleeds also occurred in the trial in the shoulder, wrist, and hand, and hip. And also there were soft tissue bleeds like in the muscle, mouth, or nose. And one of the highlights that we're showing here, but I'll get into that in more detail, is that 84% of the bleeds were, so in other words, bleed control was achieved in 84% of the bleeds with just one dose of 225 micrograms per kilogram. So that allows for some predictability in your life. So again, not all, but most, as you can see, of the bleeds on the higher IDR resolved with just that one single dose. And now we're going to get into more details on this. So if we look at the 75 microgram per kilogram IDR, at hour 3, which is the single dose efficacy, because that would be only one dose would have been given by hour 3, 29% of the bleeds were controlled. By hour 12, it was up to 82%. Remember, that was the primary endpoint. And by hour 24, it was almost 97%. So that's for the lower 75 microgram per kilogram IDR. For the 225 microgram per kilogram IDR, as I sort of already alluded to, at 3 hours, 84% of the bleeds had achieved successful bleed control. Essentially, that was maintained through hour 9, 84%. By hour 12, it was 91%. And by hour 24, it was 99.5%. So that's where this 84% bleed resolution at 3 hours comes from. And also keep in mind that with this dosing regimen, you would only give a second dose at hour 9. So that's where also the 84% comes in when we say only a single dose of 225 micrograms per kilogram led to quick bleed control at 3 hours, but also lasting bleed control. Because remember that you could not give any additional doses of 7-FAC once the bleed was controlled, because otherwise that would not be considered a success. If we look at the two treatment regimens side by side at 24 hours, you can see that at that point they're fairly similar. So the difference really is in the early part of the treatment phase where there's a difference. Remember, at hour 3 for 75 micrograms per kilogram was 29%, whereas for the 225 microgram per kilogram dose, it was 84%. By 24 hours, these are essentially statistically the same, and essentially almost all, not all, but almost all the bleeds were resolved with both. And then importantly, rebleeding is quite common in patients with hemophilia A or B with inhibitors when they have a joint bleed. But in this case, there was only a single event of rebleeding among all the 465 bleeds. So that's 0.2%. So really very uncommon, very, very uncommon actually, for any rebleeding to occur in this study. If you want to look at that visually, so here's a little visual showing you 447 bleeds on the left side that did not reoccur. And the recurrence was 24 hours after the treatment with 7-FAC, and only one did recur. So that's another important aspect that was identified in the clinical trial for the efficacy of 7-FAC, a low rebleed rate. So briefly, we're going to talk about severe bleeding episodes, and these are defined typically as potentially life or limb-threatening. So the bleed is so bad that you could lose an arm or lose a leg, or bleeds that can cause permanent damage in the nervous system, either in the spinal cord or in the brain. And we are showing you just the different types of bleeds in the brain depending on the location. Inside the skull, whether it's outside the brain, epidural, also outside but closer to the brain, subdural. In the brain substance would be intracerebral, and then in a couple of other compartments. There's different compartments in the brain. I can tell you that all of these are very serious and can lead to significant permanent neurologic damage. So regardless of the location of these, we lump them together. You'll hear the term intracranial hemorrhage. Cranium refers to the skull, so any bleeding inside the skull, even if it's not directly in the brain tissue, but they can all result in pressure and harm to the brain. There were 3 severe bleeding episodes in the PERCEPT-1 trial, and all of these were successfully treated. But first, you can see that the treatment regimen, if a patient perceived that that bleed was severe, and the patients would make this call at home, was a little bit different. So first, they had to use the 225 microgram per kilogram dose. So even if they were on the portion of the trial where they were assigned to the 75 microgram per kilogram dose, they had to use the 225 if they deemed their bleed was severe. Second thing you'll notice is that they could then give an additional dose, not at hour 9 for the mild or moderate bleeds, but at hour 6, so 3 hours sooner. And that dose is all 75 micrograms per kilogram. So all subsequent doses are always 75 micrograms per kilogram. And the second thing you'll notice is that additional doses could be given every 2 hours for these severe bleeds, rather than every 3 hours for the mild or moderate bleeds. So if we look at these 3, one had a traumatic intramuscular bleeding episode. He received 1 dose of 225 micrograms per kilogram of 7-FAC, and his bleed resolved. The second patient had a spontaneous renal hemorrhage, so bleeding in his kidney essentially, and he received 5 doses of 7-FAC, the 225 dose at hour 0, and then 4 additional doses at hours 6, 8, 10, and 12. So by 12 hours, his bleed had resolved. And the last one was a spontaneous hip bleeding event, again, receiving the 225 dose, and then an additional dose at hour 6 and 12. And don't worry about that protocol deviation. It just means that this patient skipped the hour 8 and 10 dose, which happens sometimes in clinical trials. The main point here is all these severe bleeding episodes achieved this by 12 hours and did not require any retreatment. Okay, so now that we've talked about the efficacy, in other words, how well it works to control bleeds, we now have to talk about the safety of 7-FAC. So what is the most important information you should know about 7-FAC? So the most serious possible side effect of 7-FAC is abnormal clotting involving blockage of blood vessels, which could include stroke, blockage of the main blood vessel to the lung, which is a pulmonary embolism, or deep vein blood clots or deep vein thrombosis. Remember that box warning for thrombosis? This is a possible side effect of 7-FACT, and it's highlighted in the box warning with a little more information here. So you should know the signs of abnormal clotting and seek medical help immediately. And what are those signs? They could be signs of clotting in places other than your site of bleeding, which could include new onset of swelling and pain in the limbs, which could be the sign of a deep vein thrombosis. New onset of chest pain or shortness of breath, which could be the sign of a pulmonary embolism or blood clot in the lungs. Loss of sensation or motor power, or altered consciousness or speech, which could be the sign of a stroke. So that's part of the important safety information. As far as what is 7-FACT, I think we've already gone over this, so I'm not going to read the indication a second time. It's basically the same thing that I already told you about adults and adolescents with HEMA or B with inhibitors. But in addition, it does say that injecting medicines require special training. Now, if you're older than 12 and you have HEMA and B with an inhibitor, you probably have already received all of this special training. But the point here is that if you're new to an inhibitor, do not attempt to self-infuse unless you have been taught how by your healthcare provider. Now, who should not use 7-FACT? You should not use 7-FACT if you are allergic to rabbits. I will make a comment on that momentarily. Or if you have known allergies, or if you have known allergies to 7-FACT or any of its components. If you have an allergic reaction, so you should seek immediate medical help if you experience things like hives or itching or rash or difficulty breathing with cough or wheezing or swelling around the mouth and throat, tightness of the chest, dizziness or fainting, or low blood pressure after taking 7-FACT. And then, of course, tell your healthcare provider prior to using 7-FACT if you have begun treatment of a bleeding episode with another bypassing agents. So what's the deal with the rabbits? So basically, 7-FACT is made in a somewhat unique way for medications in that it is actually produced in live rabbits. So the gene for 7-FACT, the human factor 7A gene, in other words, or the gene for 7-FACT is put into these rabbits. These rabbits are held in a facility that I got an opportunity to visit. It's obviously a very sterile, safe facility. And then the rabbits actually, because they have this gene, will express the protein in their milk. So yes, the rabbits get milked, and from the milk, the 7-FACT is then purified. So if you're allergic to rabbits, that is why you should not use 7-FACT. What should you tell your healthcare provider before you use 7-FACT? Well, you should tell your healthcare provider if you are pregnant or nursing or plan to become pregnant. Now, yes, I know hemophilia patients are mostly males, but there are females that have hemophilia A and even some with inhibitors. So this can be relevant for those patients. If you have had prior blood clots, heart disease, or heart failure, abnormal heart rhythms, prior pulmonary clots or heart surgery, or if you have or have had any other medical conditions. So, of course, when you go to visit your doctor, especially if you go see a new doctor, they're going to not just ask about your hemophilia history, but they should ask about all your medical history so that they understand any other conditions that are not necessarily hemophilia or related to hemophilia, because that may be important in making a decision on whether 7-FACT would be safe for you to use. Now, what are the possible side effects of 7-FACT? The most common adverse reactions, and I'll show you a table shortly, that were seen in the trial were headache, dizziness, infusion site discomfort, infusion site hematoma, meaning bruise, and infusion-related reaction, meaning some sort of chills or fever after the infusion, and fever. And of course, again, seek immediate medical help if you have signs of a blood clot or an allergic reaction. And then on the bottom here is that if you experience an alert, any sort of adverse reaction or even a suspected adverse reaction to 7-FACT, or you have any complaints about the product, you have different ways of reporting that, either to the company, HEMA Biologics, as you see there, or through the system the FDA has called MedWatch, and you can see the website there. So back to the production of 7-FACT, I mentioned that it's produced in rabbits, but then it goes through this extensive purification process, removing any viruses that may have been in the rabbits. Again, these rabbits are kept in a very sterile environment. They do not get to play outside, if you will. They have to live in this facility. And they are kept apart from other animals where they could get viruses. But still, Even with all that, there is a viral inactivation step. And then the other three steps, and exactly what all those terms mean is not really that important. The point is that all of these steps are aimed at purifying the 7-fat protein from this rabbit milk so that at the end of the day, when you look into that package and you look at the 7-fat, it is essentially purely the protein plus what we call the excipients, or in other words, these are the materials that can keep the product, for example, help to make it in a powder form and keep it stable and keep it at a good pH. So the safety profile. So we just discussed this, but here's a table showing you the number of adverse reactions that occurred in the clinical trials. Now, this is looking at all the clinical trials. We discussed the Percept 1 trial, which had 27 patients, but there was earlier trials that had 15 patients. So you can see 42 total patients. That's what the N equals 42 means. And in the table, I'm not going to read every number here. I think it's pretty clear. But you can see that most of the adverse events were related to the infusion, either discomfort or bruising or a infusion-related reaction. Now, in the 7-FACT clinical trial, there were no inhibitors that developed to 7-FACT. No allergic reactions occurred either. However, it does not mean that you cannot get an allergic reaction to 7-FACT. It's just in the trial, we didn't see any. And also, there were no thrombotic events reported in the trial. But again, it does not mean that it cannot happen. So the way we interpret this is that in the clinical trial of these 27 patients who treated 465 bleeding episodes, none of them had an allergic reaction and none of them developed a blood clot. So that's providing some positive evidence of safety, which is what allowed the FDA to approve 7-FACT. But just because there weren't any in the trial, the point is that it doesn't mean that it can never happen. An allergic reaction, even an inhibitor to 7-FACT, and certainly a thrombotic event as well. So they can all happen, although we didn't see them in the trial. So 7-FACT is convenient to store and convenient to use. It can be infused in 2 minutes or less. 7-FACT can be infused up to 4 hours after reconstitution. So once the powder and liquid are mixed, you have up to 4 hours to infuse it. And so what that kind of means to me is that if you're having trouble finding a vein, you can have a little bit of time to try to call for help, either through a home nurse, or if you're close enough to the hospital or your treatment center, that you could potentially still use that up to 4 hours if you're having trouble finding your vein. It's easy to store. It does not need to be refrigerated. You can see the temperatures where it should be kept at. So basically, most people are going to keep their house between 36 and 86 degrees. So anywhere in the house is fine as long as it's protected from light. And in the package, it would be protected from light. And you should not freeze 7-FACT. Again, once it's reconstituted, then it's stored at room temperature for up to 4 hours. And again, you don't reuse it, so don't freeze it or store it in syringes or put it back in storage. Once it's reconstituted, it needs to be used, and if for some reason it's not used, then it needs to be discarded. So a little bit of a comparison we're going to do here between 7-FACT and the other factor 7A that is on the market called Novo7, that I'm sure many of you have heard about because it's been around for a long time. So first of all, Novo7 only has one dose, which is 90 micrograms per kilogram. That is the only approved dose of Novo7. And Novo7 is meant to be infused every 2 hours to treat bleeds. And like 7-FACT, it is dosed every 2 hours until the bleed is resolved. So when you look at that timeline, it doesn't mean that every bleed requires all those doses. But the point is that if it's going to take 12 hours to treat a bleed, and you can look at that on the table just below on the left. So if it's going to take 12 hours for a bleed to get controlled, then you'd be using 6 doses of Novo7, meaning you'd have to do 6 infusions of Novo7. Whereas with 7-FACT, with the high IDR, you'd only use 2, one at hour 0 and one at hour 9, as you can see in the timeline above. If it takes 24 hours to fully treat a bleed, then with Novo7, it would take 12 doses, and with 7-FACT, it would take 6 doses. So that's a bit of a comparison between the two drugs in the sense of the number of infusions that might be needed to control a bleed based on the prescribing information for both. And then 7-FACT comes in a box, in a kit, kind of like all the other factor products. in a sense, except what you see here is that there is the vial that contains 7-Fact, and then there's a pre-filled reconstitution syringe. So there's not a second vial, but there's a syringe. That does make it a little bit easier. There's a vial adapter, and then, of course, the instructions for use. And the pharmacy will provide the infusion syringe and other infusion supplies that depend on your dose and your weight. Because remember, all the doses are based on your weight. 75 micrograms per kilogram or 225 micrograms per kilogram. And 7-Fact has 3 vial sizes, 1, 2, and 5 milligrams. And so depending on, again, your size and your dose and the prescription your doctor gives you, the pharmacy will dispense the proper number of vials. So let's say, for example, your dose is going to be 7 milligrams for the 225 microgram per kilogram dose. You would have a 5 and a 2 milligram vial, just as one example. So getting to the end here, these are some reasons to consider 7-Fact. First, the rapid action. So remember, 84% of mild and moderate bleeding episodes were controlled with just the one dose of 225 micrograms per kilogram at 3 hours. So 3 hours, you have this rapid action. And then also that single dose efficacy, meaning 84% of the bleeding episodes were controlled by 9 hours. So again, that means you only need to do one infusion, and that one infusion for 84% of the bleeding episodes will work within 3 hours. In this study, we had 0 thrombotic events, 0 antibodies against 7-Fact, and 0 treatment-related severe adverse events. So those are the more severe side effects. Again, it doesn't mean those things cannot happen, but in the trial, we didn't see any of those. And then the efficacy, we went through that, so I'm not going to read that off to you, the 12 and 24 hour. I mean, the figure is self-explanatory, and we've already discussed that. And then finally, the low rebleed rate of 0.2% and the fact that 7-Fact may offer fewer infusions to control a bleed. So what about Hemlibra? So, most hemophilia A patients with inhibitors in the United States are on Hemlibra to prevent bleeding because Hemlibra is a drug that is effective at preventing bleeds in patients with hemophilia A with inhibitors. But it's important to remember that Hemlibra is only for bleed prevention. When bleeds occur, then patients will have to use a bypassing agent. And because this trial, the Percept 1 trial, was done before Hemlibra became widely available, the patients on this trial were not on Hemlibra, in case you're wondering. And that's, again, this trial was done in the years before Hemlibra became broadly available. So MASAC, which is the Medical and Scientific Advisory Council of the, it should say, I guess, NBDF now, National Bleeding Disorder Foundation, what used to be NHF, National Hemophilia Foundation. So this is a group of physicians, scientists, nurses, pharmacists. They put out a guideline that supports the use of 7-Fact at the lower IDR, 75 microgram per kilogram, for the treatment of breakthrough bleeding events in patients on Hemlibra, even though in the studies the patients were not on Hemlibra. So again, getting really now to the very end, the question is, could 7-Fact be an option for you? So of course, this is a decision only you and your healthcare provider can determine. So I encourage you to, if you have hemophilia A or B with inhibitors, to discuss, how you manage your bleeds when they do occur. And you might want to consider a discussion of 7-Fact. And if you have an interest in it, then yeah, talk to your healthcare provider about whether it could be a treatment option for you. And some of the questions to think about would be, how long does it take to get a bleed under control currently for you? How many doses are you using to stop a bleed with your current therapy? And how often, for example, do you have to get up in the middle of the night to do an infusion? And then what can you ask your healthcare provider? Well, you can ask them, would 7-Fact be an option for me? If it is an option, which IDR is appropriate for me? And then how would 7-Fact fit into my overall current treatment regimen? And so, yes, we are really getting to the end here. This is the HEMA Biologics. So the HEMA Biologics is the company that makes 7-Fact, and their support program is called HEMA Biologics Cares. And you can see the list there of all the different support services, and you can see ways that you can call or go on the website, 7fact.com, to get more information. But essentially, There's a copay savings program for patients who may have a copay for 7-Fact. Their patient assistance program for patients that don't have health insurance, and in that case, 7-Fact could be provided at no cost for patients who meet certain income criteria. There's a quick start program, so we can get, or HEMA Biologics Cares can get a few doses to you to start with while your insurance coverage is getting sorted out. A bridge program is if you've already been on 7-Fact and now you've changed insurance and or some other reason there's a delay in getting a prescription, they can bridge you over with some doses of 7-Fact. And then, depending on your hematologist or treatment center, they may need some help in helping you identify your coverage so they can support a benefit investigation and coverage determination, and getting a prior approval as well if needed. So this is really the end. Before the questions, you can connect with a 7-Fact patient advocate. There are 2 patients you can see listed there, one with both with hemophilia A with inhibitors, one in his early 40s, Benjamin Denman, and one a little bit older, Matthew Compton, and then a mom, Rachel Katzman. They've all been identified as patient advocates that you can, if you want, get in touch with them through that number that you see below, and they can discuss with you any questions you might have about 7-Fact through this patient advocate phone program, and you can connect with them via email as well. You can see the email address there. Yes, and I'll leave this up. Actually, I think the next slide is just saying, I'll put this slide up for a second. This is where you can get more information, the website, a phone number, and even an email for HEMA Biologics. I'll go back a slide. If you want to scan the QR code, that will take you to their real life stories that you can listen to as well. So I think what I'll do is put this slide back up so you can take a look at the website and the phone number and the email address. And these slides will be available after anyway, and then we can take some questions, but I'll just go back and leave the QR code because I know sometimes it's clunky to get that QR code onto your phone, and we can start the Q&A at this point.
Great. Thank you very much, Dr. Young. Really great to hear about 7-Fact and how it can be used to help manage hemophilia with inhibitors. Just before we do start the live Q&A, I just want to remind our audience that we dropped a link into the chat. You can find the chat button at the bottom of your screen, and if you click on it, you should see a link to the 7-Fact PI, so you can follow that and maybe save that somewhere if you want to go back to it. And we've also put that into the comments on our restreaming platform, so you can take a look at it there. And as I mentioned at the beginning, we will have to let our restreaming audiences go at this point, unfortunately. So thank you so much for joining us. If you wanted to be part of the live Q&A, hop on over to the Zoom platform and you can participate there. Do come back also next week. We have the 3rd installment in the NBDF HTRS Research Journal Club, and this is going to be a discussion of new gene therapy treatments with Dr. Lindsay George. So I hope you can come for that.